Welcome to This Explainer. Today, we're diving into a real medical mystery that unfortunately leaves countless patients suffering in total silence after standard knee surgeries. We'll be looking at a really fascinating anatomical study published in JPRAS Open that tries to solve a massive problem in postoperative recovery. You know, for a lot of folks, routine knee surgery is supposed to be the finish line for their pain, but for a really significant percentage, it's actually just the beginning of a completely different kind of agony. So today, we're tracking down an incredibly elusive nerve branch to understand exactly why our bodies can be so darn complicated to fix.
Imagine waking up every single day with a brutal, agonizing combination of symptoms. The source material literally describes the pain as sharp and burning, often paired with conditions like hyperalgesia, where you have an extreme response to pain, and allodynia. And with allodynia, basically even a light touch, like your pant leg just brushing against your knee, feels completely agonizing. So we aren't just talking about a minor ache here. This is severe neuropathic pain that completely derails a patient's quality of life, making basic rehab and everyday functioning just incredibly difficult.
And so that brings us to the big question for this explainer. If we know the pain is caused by a nerve injury, why do surgical attempts to fix it fail so often? I mean, usually when patients don't respond to regular therapies, surgeons will try a procedure called denervation. That essentially means they surgically cut or remove the affected nerve to stop those pain signals from ever reaching the brain. Sounds foolproof, right? But in practice, the results are highly variable. In a lot of really frustrating cases, patients wake up and experience absolutely no pain relief whatsoever.
Section 1. The Knee Pain Mystery.
Let's actually set the stage here, because we need to understand how common and honestly how frustrating this roadblock is. Just look at the sheer scale of the problem. According to the data, nerve injury of the saphenous nerve or its infrapatellar branch complicates anywhere from 21% to a staggering 69% of certain knee surgeries and traumas. We are talking about super common procedures here, things like ACL reconstructions or fixing open tibial fractures. With incidence rates that high, relying on a denervation procedure that randomly fails just isn't acceptable. So the researchers hypothesized that maybe these failures weren't due to bad surgical technique at all, but rather due to wild anatomical variations from person to person.
And to figure out why these procedures were failing, the researchers essentially built a literal treasure map out of the human leg. Looking at this sketch from the study, you can see how they divided the thigh and knee area into these really precise horizontal and vertical segments. They actually dissected 18 cadaver limbs to carefully track down the primary suspect for this postoperative pain, the infrapatellar branch of the saphenous nerve. Basically, they wanted to map out exactly where this nerve travels and, more importantly, where it actually originates.
Section 2. Hunting the elusive nerve. So, treating this whole thing like a medical detective story, the researchers had to hunt down a nerve that basically changes its location from person to person. They needed a standardized way to measure something totally non-standard. Step 1. They inserted these thin, rigid medical wires, called Kirschner wires, just to perfectly define the medial part of the knee joint. That gave them a strict baseline. Then, Step 2. They carefully found the saphenous nerve and its infrapatellar branch near the knee and traced them backward or proximally up the leg. And finally, Step 3, they measured the exact point where the infrapatellar branch split off from the main nerve relative to that wire baseline they set up at the knee.
Section 3. Mapping the branches.
Okay, if you ever thought the human body was wired perfectly, like some mass-produced machine, this next part is totally going to change your mind. Imagine hiring a contractor, right? And they wire every single house in your neighborhood completely differently. In one house, the fuse box is in the basement, in another, it's up in the attic, and a third, it's out in the garage. Well, that is exactly how the infrapatellar branch behaves in our legs. It's supposed to branch off the main nerve to provide sensation to the front and inside of the knee. But as they mapped it out, they realized the spot where this nerve actually splits off is incredibly inconsistent.
Looking at the actual numbers across the 23 different branches they identified, the data shows a wildly erratic pattern. 10 of these branches were distal, meaning they split off between 0 and 10 centimeters above the knee. 3 separated in the middle zone, so 10 to 20 centimeters up. And get this, 9 of them were highly proximal, meaning they separated far up the leg, literally over 20 centimeters away from the knee joint. So if a surgeon goes in assuming the nerve branches right near the knee, but the patient's nerve actually branched way up near their groin, you can instantly see why the surgery completely misses its target.
To put that weirdness into perspective, the researchers compared this infrapatellar branch to the main saphenous nerve it actually stems from. The main nerve is pretty reliable. In the study, the vast majority of main saphenous nerves consistently crossed the posterior or back third of the knee joint. But the infrapatellar branch? It scattered its crossing points all over the place. 5 in the front, 15 in the middle, and 2 in the back. There are essentially 0 reliable anatomic safe zones for this branch, which perfectly explains why it gets accidentally clipped during knee surgeries so often.
Section 4. The multiple branch problem. But wait, unpredictable location was actually just the first half of the mystery. The second half is a massive plot twist that finally explains the huge failure rate of these denervation surgeries. Out of the dissected limbs, researchers found up to 3 separate infrapatellar branches hiding inside a single leg. Yeah, 3. I mean, most medical textbooks will tell you there's just a single nerve branch, but this study absolutely proves that some people naturally just have multiple infrapatellar branches routing pain signals straight from their knee.
And here is the ultimate aha moment of the whole study. If a patient is suffering from severe nerve pain and a surgeon goes in, finds the infrapatellar branch and cuts it, they're probably thinking, great, job well done. But if that patient unknowingly has a second or maybe even a third branch hidden away in their leg tissue, those agonizing pain signals, they just keep right on flowing to the brain through those extra routes. The surgery didn't fail because the surgeon messed up. It failed because they were working with an incomplete map of the patient's totally unique wiring.
Section 5. A new diagnostic strategy. Now, armed with this crazy new anatomical evidence, the researchers didn't just leave us with a problem, they actually proposed a really optimistic practical solution. Instead of gambling on the totally unpredictable lower leg area near the knee, doctors should use a much more proximal, ultrasound-guided nerve block way higher up the thigh. By doing a diagnostic block higher up, doctors can see if the pain stops. If it works, it tells the surgeon the branches must split off further down. If it doesn't work, it means the nerve branch is incredibly high up in the thigh. This simple shift helps accurately identify which patients are actually good candidates for surgery, completely saving others from unnecessary and doomed procedures.
So I want to leave you with this final thought. How many lives could actually be reclaimed from chronic agony now that we finally have the blueprint to solve this elusive medical mystery? By simply acknowledging and adapting to the fact that human anatomy is messy, highly variable, and super unpredictable, we can finally move away from these one-size-fits-all surgeries. Using proximal ultrasound blocks is a massive step forward in actually personalizing pain management. Thank you so much for joining me on this explainer. Keep questioning those standard blueprints and never stop learning.